Okay, today we're talking about Cushing's, which is, I get really bored about Cushing's for two reasons. One is that we see so much of it and it's so common and everybody knows how to diagnose it. And the second is that it's really controversial. So you speak to different people and you get a different answer. And that I find frustrating because you can't make an exam question about it. So there are sort of select areas within Cushing's that you could make an exam question about, but I do want everybody to leave here having learned something about Cushing's. So does anybody have any specific clinical signs, diagnosis, management questions they want to discuss today? No. Can we just talk about other stuff then? Everyone's so quiet today. It's weird.
But if anyone else has any things they want to specifically talk about.
Nothing specific. Is anybody interested in atypical Cushing's?
Yeah, sure. That sounds good. I have one question, Anna.
Yeah.
Why is it, do we only, I feel like every practitioner kind of reaches for ACTH-DIM first, myself included.
Mm-hmm.
And is it just because it's more convenient because you only have to do it over an hour or so than the animals in hospital, or is there actually benefit of ACTH-DIM over the low-dose dex?
Oh, it's a really good question. Okay, so let's do a whole section on testing. Like we'll definitely sort of go deep into that and we'll talk about sensitivity and specificity, which Josh will define for us when we get there. Sorry. Start Googling quick. So we might come back to that, and let's just start really quickly on what, again, this is going to be a bit of a controversial, I don't want to start a philosophy discussion, but what clinical signs would you look for that would warrant investigation into Cushing's disease? So what are some of the, I guess my question is not what might we find on physical exam and blood tests, but what are the complications that Cushing's causes that should be our trigger to look for it?
Polydipsia is one.
Good.
Polyphagia, panting.
Are they problems?
They can be, like if owners perceive panting, like the dog's panting at home all the time.
Yeah.
If it's not primary pulmonary disease, then you do have to have like endocrinology in your mind.
You do, but is it a problem? Like we tend to sort of address the client's issues when we're investigating diseases and blood test results and things, but is panting a problem?
In my mind, it is. I don't know. Is that wrong?
No, I mean, it's a problem that I put on the problem list for in an exam for sure, but does it cause disease?
Oh,
Are these dogs hypoxemic? Are they exercise intolerant? What's the part that's impacting their quality of life?
No, in that sense, not really. But having said that, I don't know, like in terms of literature, we know that hyper-A can cause hypercoagulability and they're more prone to pulmonary and thromboembolism. So
Good.
whether...
Excellent. That's where I wanted to go.
Yeah.
Thanks. Excellent. So you're exactly right. So panting can be a big problem in dogs. And what's the cause of panting in these dogs?
Never really thought that.
It's they get thinning of their diaphragmatic muscles and abdominal musculature, so they have to kind of work harder to get bigger breaths. Good,
exactly. So if you measure a dog with Cushing's, will have a lower tidal, or a dog on exogenous steroids will have a lower tidal volume than other dogs. So we have weakening of the diaphragm muscles. So the back of the chest moves back less with every in-breath, which means the side of the chest has to move out more, which increases the work of respiration.
I didn't know that. Thank you. Yay, learned something today.
Yes, one down. Awesome. So we've got weakening of the diaphragmatic muscles. What else might decrease diaphragmatic movement other than the muscle weakening?
Could it be?
Yes. Hepatomegaly.
Yeah.
Yep.
By the way, this is Katie. She's a final year student.
Hi,
She's
Katie.
about to graduate. So
And Anna.
nice meeting you. Are you working at Terry Hills eventually? Yeah, she's going to join.
Oh, we met there, didn't we? Yes. Did we?
Or
Maybe.
she's starting in the new year.
Okay, lovely. Yeah.
So
Awesome.
she will be part of the local community soon.
Okay, Katie. I'll remember that. I'll just make a note here, Katie.
When did you start?
January.
In January, there you go, yeah.
Beautiful. I knew there was a new grad starting. I wasn't. Now I've got a face to the name. Okay, so big liver. What causes the big liver?
Steroid, like metabolic change.
That's like what you'd write in a radiology report, Alex.
Yeah.
Josh, what causes the big liver?
You get like a vacuole hepatopathy, so more storage of fat.
Good.
Yeah, and also so active, it's you're breaking down glycogen, that kind of thing. So you're getting all these metabolic changes.
Yeah, absolutely. So think of cortisol as it's a hormone that is setting your body up to survive a famine. Excuse me. So you've got to store everything you're going to need. When food supply just cuts off all of a sudden, everything you need has to be in your liver. So that's the objective of of excess cortisol. So we get big liver, we get weak diaphragm, we got decreased tidal volume, and then I want to just go into Pooja's point about the hypercoagulability. This is such a deep question. What is the mechanism of the hypercoagulability in Cushing's disease?
I've often wondered that.
Yeah, it's multifactorial, so you throw it out there, you're probably right. There's
No,
history.
So it's not one of those no one knows things. Okay, I don't know.
Anna,
Yeah.
is part of it loss of antithrombin?
Yes, it is. Yeah. So hypercoagulability, there's 3 components to it. When you're thinking of hypercoagulability, I want you to think of, you can have excess coagulant factors. You can have decreased endogenous anticoagulants. So there's less anticoagulation just in circulation. So there's relative increase in clotting factors. And then you can get decreased fibrinolysis. So more clot formation, less clot inhibition, and the clots hang around for longer. And that's, I started a master's and then a PhD in coagulation associated with Cushing's. So I've spent a long time watching dogs with Cushing's clots form. And their clots hang around for like at least 10 times longer in a lab setting than normal dogs' clots. So when you think that clot that would normally, you had a like bruise and a blood vessel got damaged internally, the clot that forms the plug there is going to hang around for 10 times longer. So the chances of that getting caught up and going off into circulation are much higher. Make sense?
Mm-hmm.
So what are the 3 causes of hypercoagulability that I just told you?
Okay. So increase in clotting factors,
Yes.
decrease in anti-clotting factors,
Good.
and the third one was decrease in antithrombin.
Ooh, which is actually one of the anticoagulants.
Sorry, decrease in fibrinolytic.
Yes, good. Exactly. Delayed clot breakdown. Excellent. Thank you, Jeff. Did everybody else know that too?
We're listening.
Yeah, good. Awesome. So what percentage of dogs have...
I forgot.
Beg your pardon, Jeff? Sorry.
I had to repeat it before I forgot.
Yeah, that's why I asked again, because I feel like clotting, everyone goes, oh, too hard, and they like have this barrier to it. But like if you break it down, stop looking at the components, it's pretty simple. So dogs with Cushing's have excess procoagulant factors. So a lot of their factors are high when you look at it. So increased thrombin levels, increased fibrin levels, or fibrinogen levels, increased 8 as well. So all of those really important factors. They've got decreased antithrombin, decreased protein C as well, I think. Well, might as well throw protein S in as well. It's got some of the, lost some of the anticoagulants. and they've got delayed clot breakdown. So all of those things are in excess. And the other thing they've often got on hematology, which might impact clotting, is thrombocytosis. Beautiful.
I must admit, until now, I actually thought that the only reason that they were like likely to throw a clot is because of the thrombocytosis.
Yeah.
So much other stuff behind it that I just didn't.
There's so much derangement of
I was like, oh, they have high
regulation.
platelets. They're going to throw a clot. But
Yeah.
there's not much more.
I look at that and I think, how often is this happening that we're not detecting it?
Mm.
Because we don't see DVTs in dogs, like they just don't present with them. So how often is there clots in veins that we're just missing? Can you guys hear the background noise, or are we good?
Good.
Great. Okay, super. I'll save my shush. I'll keep it up my sleeve. Okay, good. So how many dogs have PTEs as a cause of their panting?
I have no idea.
No idea.
It's very hard to diagnose from pulmonary thromboembolism, so we probably
Good.
will never know.
Exactly. So the studies are quite low that dogs just have incidental PTEs, but there's they think it's very underrepresented, and Dave Church is like, all of the dogs have PTEs, that's why they're panting. That's his opinion. And he knows Cushing like nobody else. So I'll take his opinion on that.
Is that humans also get undiagnosed PTEs? Like, is that a thing? I just thought it was always catastrophic.
Oh no, humans complain more than dogs, so they get diagnosed more often.
Right.
Humans,
Shortness of breath.
yes, sudden onset shortness of breath. In humans, they're normally diagnosed at the DVT level. So most PTEs come from the legs.
Right. You're already in hospital, probably.
Yeah, exactly. So there's some predisposing factor, and they're being watched for them. They've got preventative measures for them. They're on anticoagulants when they've got those kind of comorbidities and stuff.
So we'd probably talk into like micro ones in dogs if they're very, very common.
Exactly. Yeah. So tiny little thrombi that are just knocking out tiny little bits of the lungs, but just increasing the number of breaths that the dogs need to take.
Cool. Thanks.
Now, the next question I want to ask is, how many of these dogs are hypoxemic? And I had a stat for you, and the only reason I ask it is because I want to tell you my stat, and now I can't find the answer. Can anyone have a guess how many are hypoxemic?
I think it'd be fairly low.
You'd
Yeah.
think so, wouldn't you? Why didn't I write this down?
They seem to function fairly well.
Then again, so do lots of pugs and Frenchies.
That's a very good point you make.
Well, that's right. And when you start doing MRIs of flat-faced dogs, and then you discover some of their brain stems actually gone through the foramen magnum, and they're still functioning quite normally.
It's quite remarkable, isn't it? Oh, it was such a high percentage. I was so surprised. Oh, 33%.
Oh,
are
wow.
hypoxemic.
Very small.
The pool.
Yeah. So a third of them.
The fellow doing the pool. We need to pay him.
Yeah, so I do think, like, as far as, you know, the initial question I asked is, like, let's talk about the problems that we should look into, the sort of presenting signs that are indications to do an investigation into Cushing's. I do think panting is one of them. If the owners present with panting as a complaint, I think it warrants investigation and potentially treatment. What other complications are there that Cushing's causes that would warrant investigation and treatment?
Gallbladder mucocele formations,
Good.
seed sludge in the, I mean, sludge is not the same, but like sediment, and then it's sort of increasingly getting more, what's the word, mucinous hyperplasia or whatever.
Yeah, mucinous hyperplasia, and then mucocele. So there's sort of sequential series of events. Do you know what the odds ratio is for, I just, another stat I want to tell you and put you on the spot before I tell you it, of a dog getting mucocele that has, so if a dog has a mucocele, what's the odds ratio of them having, how do I word this?
I wouldn't know the answer to that. Whatever
No.
the numbers, I don't know.
Really high. So 20, it's the odds ratio of Cushing's being associated with mucocele is 29 times.
Wow.
It's
Just
the
knew it was
most-
high, but not a number. So 29.
Yeah, 29 times. You never need to know that for an exam. Don't get me wrong. I just like it's so likely to be present when you see a mucocele. And obviously, what we probably should be talking about as well is what resolves with treatment of Cushing's and what doesn't. So, does anybody know what the mechanism of mucocele formation is with Cushing's disease? Does anybody know?
I feel like you're leading us into a no one knows kind of answer, but
No one knows. Yeah, so everyone's got theories. They think that there's decreased gallbladder motility associated with hypercholesterolemia, and because Cushing's is the most common cause of hypercholesterolemia, we see high cholesterol levels in another stat, 66% of dogs with Cushing's. We get decreased gallbladder motility, which means we've got stasis of bile. Bile's very irritant, and we get inflammation of the gallbladder wall, and then we get swelling with like really mucousy, thick stuff, which then delays motility even more, and then we just get a rock forming in there. So that's definitely an indication to look into Cushing's. Can you test for Cushing's when they're in hospital for a mucocele?
Because they're probably going to be stressed anyway, so you might get a false elevation of cortisol levels.
Exactly. It would be very inappropriate for a dog with a mucocele not to have an elevated cortisol. It needs extra cortisol in that situation. Excellent. What other complications do we see?
UTIs.
UTIs, good. Do you want to do more stats? What percentage of dogs with Cushing's have a UTI?
1/3, I don't know, 33%.
Oh, higher, warmer. Half, yeah. Half have a non-clinical UTI if you test them all. What percentage are clinical?
The other half.
No, sorry. Half have a UTI, full stop. Sorry. I worded that badly. Good point. So it's only 5% are clinical for it. What are the rules about treating UTIs that are non-clinical?
So subclinical UTIs ideally, unless there are, if there are no clinical signs, ideally you shouldn't anymore be using antimicrobials. However, with underlying disease processes like endocrinopathy or like even diabetes, I don't know, it's a very divided opinion. I'm always confused about this, what to do, because it's not really antimicrobial stewardship, but at the same time, I don't know.
Yeah, I just don't test unless they're clinical. And then I don't have to make a decision.
Yes, that's a very good thing to do. I will continue that.
Yeah, I'm going to treat the Cushing's. I'm going to make the urine more concentrated, and then it's going to return its innate defenses, and we can pretend we never thought about it.
Just off topic a little bit, but I don't know if you can answer. In diabetes, obviously you're testing because it can make it harder to control. Would you treat UTI if it's subclinical?
Probably more so with diabetes than I would with Cushing's.
Okay.
It would depend if they had renal compromise and diabetes, then absolutely, because pyelonephritis is going to be devastating in that patient. If we've got diabetes that we're just diagnosed and we're going to get on top of it, and the glucose level in the urine is going to come down really fast because they're really motivated owners and we're going to be able to really tightly manage it, then maybe not.
Okay.
And they were otherwise healthy patients, maybe not. But actually the same goes with Cushing's. So Cushing's, where diabetes has the glucose and it's a great environment for bacteria, and therefore they're so much more likely to get it. Cushing's have immunosuppression, and therefore they're more susceptible to pyelonephritis. But there's so much urine coming down their ureters that most of the bacteria trying to climb up there are going to get flushed out. So it's a bit of a, maybe you can get away with not. But certainly I'm spoiled because most of the dogs I diagnosed with Cushing's are having ultrasounds, and I've had a really good look at the kidneys, really good look at their bloods, and I can go, we don't really need to look into a UTI if they're not going to treat it.
Cool. Great. Thanks.
No worries. Okay, other complications? Let's stick on the urinary tract.
uroliths,
Good. What sort?
calcium oxalate, are really common with Cushing dogs.
Excellent. So if you had a dog that was in for its 4th cystotomy and you noticed a pot belly, but there were no other symptoms of Cushing's, would you investigate?
Yeah, for sure.
Yeah, good. Excellent. And is your treatment going to decrease the incidence of calculi?
I would have. Oh, I don't know actually, because I guess. Yeah, I'm not sure.
I'd be a terrible examiner. I was just nearly had to hold my head to stop myself going. Yes, I will.
I would think if it's controlled, then maybe, but whether we're going to be able to control is the question.
So that would be an indication in my mind for tight control of Cushing's. Whereas a lot of other clinical signs, I'd say let's just control clinical signs rather than aim for a really low number. So calculi, cortisone causes calciuresis, increases the fractional excretion of calcium in the urine. And so then, a solute comes out of solution when it reaches its kind of concentration excess. So if you decrease the cortisol in the system, you decrease the concentration of calcium in the urine, and you decrease the risk that it's going to come out of solution.
Okay.
What other complications?
Hypertension as
Good.
well.
Excellent. Do you want to do more stats?
A lot of them.
A lot. Yeah. Yeah. And it depends on the cutoff you use for hypertension, for measuring hypertension, but it's between 30 and 86% of dogs with Cushing's have hypertension. Does it get better with treatment?
Oh, unless they've got atherosclerosis, because they're the only. Oh, those guys in hypothyroid dogs are the ones that can get that, I think, right?
Yeah. Yeah. It doesn't actually improve after trilostone treatment, so you can really tightly control the cortisol, but it doesn't actually improve. What's the mechanism of hypertension? Ooh, that's a hard one. Sorry.
Steroids with vasoconstriction, but it obviously isn't.
It's not.
It can only be increased vasodilation or decreased cardiac output or a combination, but just which or what, I don't know.
Is there another mechanism?
Yes, there is. What is it?
Yes, correct. Okay, well, let's go back to physiology. How is cortisol production stimulated?
From what you mean in a normal dog or in a Cushing dog?
Normal dog.
Well, I guess from the pituitary.
Yeah. What comes from the pituitary?
Oh, ACTH.
Good, excellent. And it goes to?
The adrenal glands.
Which layer?
Sorry?
Which layer?
The middle.
Donor.
No, Fasciculata.
Is it?
Yeah.
Good.
Fasciculata reticularis.
Great, excellent. Does ACTH stimulate the secretion of any other hormones in the adrenal gland?
Very small amount of aldosterone, but not much. It's mostly
Good.
potassium.
What does aldosterone do?
Increases sodium reabsorption.
And?
Increases blood volume.
Great, excellent. We got there. So what's the mechanism of hypertension?
Oh, increased blood volume.
Increased blood volume.
Good. So we inhibit cortisol production. We don't inhibit aldosterone production. And we've got, in most of our patients, pituitary dependent tumor producing too much ACTH and stimulating aldosterone secretion, fluid retention. So they get really volume overloaded.
Oh, it's hypertension they get. I thought you said hypotension.
Yeah, no, they're high.
Hypertension.
Hyper, yeah, exactly.
I used to have a lot of trouble with that in America due to the accents.
I know. Jeff, I often do ultrasounds, as you know, and I dictate as I go. So when somebody's scribing for me, and I have to say hyperergogenicity, hypoergogenicity, to make sure there's no typos, because it's really hard to tell. Or what's this word? Orally? Really hard to tell the difference between those words. Okay, any other complications? We've covered most of them, the big ones.
Pyoderma.
Oh, good. Yes, skin. I don't think about that as often as I should. Excellent. So if they're getting really severe skin problems, what's another skin problem we sometimes see?
Calcinosis pupillus.
Good. How long since anyone's seen that?
Never seen it.
5 years.
Yeah,
That's
it's
common.
Cushing's. Yeah, Cushing's is diagnosed much earlier these days than it used to be. They used to come in all crusty when I first started working in this industry, and now they're not so much.
Not so crusty.
Not so crusty. Every now and again you get a poster child and you're like, yes, that's Cushing's.
On the hypertension, if you use mitotane, does that resolve the hypertension, or is that only destroying the that doesn't destroy the medulla?
It doesn't destroy the medulla. I'm just actually not sure whether it does do fasciculata and reticularis. So that won't get glomerulosa. So we'll still, occasionally we get aldosterone level decreasing with mitotane.
Okay.
But
And if
not
you
always.
trilostane induced like adrenal necrosis, does that only involve the some part of the adrenal?
I'm so glad I've got good notes. I have no idea, did I check these?
We're seeing that a
I
lot.
don't have that written down. Seeing adrenal necrosis a lot.
Yeah.
Yeah, for sure. Around about 10%, they reckon.
How many?
Used to 10.
Okay.
They used to say 2. I don't know what the difference is, but I feel like we're seeing it more.
Kind of handy in a way.
Yeah.
A lot less drug after that.
Yeah, for sure. The only problem is that like most of them, 76% of them rebound. So you do end up having to treat them again. But the owners,
At some point down the track.
yeah, exactly. Yeah. The owners are usually then attuned to the signs and they can look for them.
Ooh, yeah.
I want to go back to panting quickly and just talk quickly about a subset of the population that we might see where panting is also a problem, and that's the dogs with upper respiratory tract obstruction. So the brackies and the LAPARD, laryngeal paralysis dogs. Panting causes edema, which is just going to make their hypoxemia so much worse. So that's, again, one of the reasons that if I saw panting, I might, in those breeds, I'd be really proactive about looking into and diagnosing and treating Cushing. Sorry, to go backwards. Let's chuck cats in there. What are the biggest complication of Cushing's we see in cats?
Oh, the skin, it sloughs off.
What? Does it?
It's
Does
okay.
it not?
Oh, it's so thin. Oh, I know what you mean. Yeah, sorry. Yeah, it's
That's the
terrible.
presentation that sometimes you'll have the skin and that's how you will trigger your mind.
Yes, good to go to look into it. It is so thin. You're exactly right. Yeah. But something more we'd see, usually diagnose this first and then go looking for Cushing's.
Is it diabetes?
Yes, it is diabetes. What percentage of cats with Cushing's have diabetes?
High.
Like 100. All of them. Except one. I've seen one. And it's not reported anywhere. Like all cats with Cushing's have diabetes because they've got so sensitive to insulin resistance. As you'd know from our last week's diabetes. Yes, so they often are presented with diabetes and then you look into it. But every now and again, there's one case that we literally called vetnostics and said, no, you're wrong, it can't be Cushing's. And they were like, it's Cushing's, you're wrong, it's diabetic. And we're like, no, it's not. Yes, so they're the main complications I wanted to talk about. Anybody got any other ones they want to talk about?
If the cats, if they're cushingoid and they get diabetes because of the insulin resistance. If you control the Cushing's, they often go into remission of the diabetes.
Yeah.
Oh, nice. Okay.
But what's a common cause of Cushing's and diabetes in cats? What might be underlying both diseases?
Being a Burmese.
also.
Acromegaly.
Yes, good.
Oh, I was like,
Okay, also. I'm here for thinking. That's not what I meant actually. Yeah, so acromegaly will cause hypertrophy of the adrenal glands, which can lead to excess cortisol and also cause obviously insulin resistance and diabetes.
Okay, cool.
The common comorbidities in a cat. Makes it harder to diagnose because the diabetes suppresses the growth hormone and then you've got cortisol as well, and yeah, complicates things. That's definitely 1% to the neuro team. I love those ones. Okay, let's go on to diagnosis. So we've kind of looked at the subset of the population where we can warrant really investigating. Clinically, you've got a dog panting its head off, 10-year-old Labrador, pot belly, ravenous, but always has been, and has some stridor when it's breathing. What testing are you going to do?
Bloods.
It's thyroid as well, but I guess if it's got hyper A, it's probably going to have
That's a good, yeah, that's a good point. Sorry, I should have classified the when I said it's got stridor, I meant it's probably, from what we've talked about, it warrants investigation into Cushing's because it's like an older dog with panting and potentially upper respiratory obstruction. So let's pretend we know that it's laryngeal paralysis. And what testing are you going to do to make your diagnosis?
Well, apart from the basic screen, I think ACTH stim might be better there than a low dose dex. Perhaps because the dog might be a bit stressed.
It's a good point. Yeah. So what are the most common causes of false positive on low dose dex?
Stress.
Stress, exactly. What about a false? So we get more false positives on a low dose dex. Okay, I said I was going to do it. Josh, what does sensitivity mean?
I'll have a go, but I feel like the more recent study, people would know better than me at this point. It's been a while since I properly thought about it. But
does anyone want to volunteer before I make Josh uncomfortable? Okay, it's all you, Josh.
well, I'm happy to be corrected. So, so sensitivity is it's a good rule out test in that it's if you've got a high sensitivity test, you're more likely to actually get the true positive that you're looking for, but you can also get a lot of false positives if it's highly sensitive. That's my understanding of sensitivity. So it's kind of, if you're looking at a test, say, let's say Cushing's, and you're doing an ACTH stim, and let's say we put our cutoff at like 200 cortisol. I mean, if we put our cutoff down at like 100, right, which is kind of into our normal range, that's going to increase our sensitivity because we're going to get all the actual cushingoid dogs in that test, but we're going to get a lot of normal dogs too.
That's a really good way of explaining it.
Yeah, it is.
Topical to Cushing's. Well done. That was excellent. So of knowing that and comparing the test, low dose dex test and ACTH stim test with the cutoffs that the lab specify, which one is a more sensitive test?
I think it's actually the low dose dex.
Exactly right. Yeah.
I don't do them much.
So we don't do them much. No, we're going to catch all of the cushingoid dogs on the low dose dex, or like really high percentage of them on the low dose dex. What's of the two, what's more specific?
The ACTH stim is something.
Good, excellent. Yeah, exactly. So we're more likely to miss a positive on a stim test, but if it's negative, it's really negative. Is that right?
Hmm.
Yeah.
the way I remember it is that a sensitive test, you get no false negatives, and a specific test, you get no false positives.
Excellent. Really good. So what's the most common cause of a false positive in a STIM test then? Because they do happen. The specificity is up to 93%, but some studies say as low as 60. So we still do get false positives in a STIM test. What's the most common cause?
Comorbidities, like if they have a mucocele or they've got gastroenteritis or something else going on.
Excellent. Yeah. So chronic physiologic stress, usually caused by disease, increases cortisol requirement, which causes hypertrophy of the adrenal glands over time. So with chronicity, that has to be over a month at least duration, we'll get hypertrophy of the adrenal glands and increased responsiveness to ACTH as a result. But you can't get a hyper result on a STIM test without hypertrophy of the adrenal gland. The normal adrenal gland just doesn't have capacity.
That's so interesting.
Yeah, it's cool, hey?
And I've been wondering, when you get a normal STIM, but you're pretty sure the dog is positive. I've asked the lab, is it better to repeat the STIM or do a low dose DEX? Sometimes I feel like I've been told that repeating the STIM is also increases its sensitivity, but I don't know how that could be.
Yeah, I think they are referring to repeating the STIM in 3 months' time once the disease has progressed.
Right,
you get more time. Yeah, exactly. So if you do it again the next day, it's not going to change its sensitivity.
Okay, right, yeah.
I got caught in Adelaide with a false positive on a low dose DEX.
Oh yeah.
My reading at the time was that it's best not to test them unless there's some evidence of them having Cushing's other than some clinical evidence of it. All that I found on this dog was a high ALP and a not so high ALT.
Yeah. What percentage of dogs with Cushing's have elevated ALP?
Oh, a lot of them.
A lot. Yeah, exactly. Over 80. What about
my understanding for like sort of diagnosis is that it's not one test, so you should never actually just base it on one thing. You have to have the clinical signs. That's like the absolute must. Then your biochemical changes, your the tests that we do, and then obviously abdominal ultrasound. It's a combination and you build a picture. You should never just look at one test and say, oh, Cushing's, and start treating. That's my understanding, but I don't know if that's correct.
I completely agree.
I've not really dealt with too many Cushing dogs. So.
And that's why I wanted to start this talk with what are the complications of Cushing's disease, because they are, in my mind, the indications to investigate for it. So if you've got an elevated ALP, it's really reasonable to do an ultrasound and rule out a liver mass or a biliary disease causing that elevation in ALP. But if you then see marginally increased adrenal size and metabolic hepatopathy on ultrasound, as Alex would report, then I would hold off until one of these complications develops. I wouldn't do any further testing at that point, because the ultrasound findings and the ALP elevation aren't enough to warrant treatment, really, in my mind. And this is where we delve into a philosophical conversation and you'll get a different answer from everyone you talk to.
Yes, one of the medics once, when I had a conversation about this, told me, okay, you don't treat, you can wait till the dog throws a clot in the brain, kidney, and something else, heart, I think he said. And I was like, oh, I mean, it is such a debated topic. Like, I don't know what the right answer is.
So in my research, which I haven't published, so I'm the only person that knows this. We tested dogs pre-treatment, post-treatment, and their hypercoagulability doesn't go away with trilostane treatment.
Right.
So
why aren't you publishing it?
Because I'm lazy. Do you want a job?
Yes.
I'm not lazy. I'm busy. And it's so boring, creature. So yeah, I published it, like I presented it. It's an abstract somewhere out there, but I haven't written a journal article. So their hypercoagulability doesn't go over trilostane. I don't know what happens with mitotane, but that, yeah, sure, wait till it throws a clot is just being an asshole. Sorry. It doesn't change whether you treat them or not.
That's Amazing.
It's interesting, hey? And that's why I've become, I think, I'm more conservative about pursuing treatment, because the hypertension doesn't resolve, the hypercoagulability doesn't resolve, the proteinuria doesn't resolve either. That's not something I forgot to mention. 50% of dogs with Cushing's are proteinuric. So if they have concurrent renal disease, you'd think, oh, that's an indication to treat. But treating doesn't reverse the proteinuria. So,
wow. But that dog where you had elevated ALP and you had a fatty liver on ultrasound, had some clinical signs at home. You're talking if they bother the owner, or you can see it's bothering the dog.
Yeah, exactly. So if the owners are like, oh, they're just exhausted on their walks, and the walks are a really big part of that dog's quality of life, then absolutely that's the reason to look into it.
Yeah.
And often you have to ask for whether the clinical signs are there, or you have to test for the hypertension, or you have to look for those complications, because they're not necessarily bothering the dog, but they are a risk to the dog that warrant investigation.
So looking a super happy fat dog with really bad skin, and the owner's not bothered and they've got no money.
The bad skin. So they're going to come to the vet clinic at least every 3 months with the bad skin, right? And cost-wise, maybe that does warrant investigation, diagnosis to decrease the future vet visits. But yeah, I mean, there's usually multifactorial causes of the pyoderma that we see with Cushing's. It's not just Cushing's. So treat the other ones first.
Very fascinating, Anna.
Sorry, go ahead.
I just have a question about like using ACTH first, just also because it rules it out if it's negative. What would then be the indication, or is there ever to use urine cortisol to creatinine? Because as a rule out, I guess. Because I know it rules out, but I'm guessing it's just less sensitive than I like the facial expressions.
I'm a terrible examiner.
Less specific than the ACTH stim.
Yes, exactly right. So it's very non-specific.
Yeah.
So most dogs who you're chasing around with a urine pot will have an elevated cortisol level.
Yeah. Okay.
In the urine. Yeah. So, and if they've got any concurrent disease, they're definitely going to be elevated. But if I'm thinking that dog with skin disease, once the skin disease is under control, and I'm thinking, oh, I really just want to know whether it's Cushingoid or not, we're in a good phase, you could catch a urine sample first thing in the morning, send it off to the lab for a UCCR, urine cortisol creatinine ratio.
Yeah.
And if it comes back normal, you're clear. You don't need to investigate for Cushing's. And it's much cheaper, much less invasive than doing a stim test.
I found I actually used it quite a lot for cases like that when I worked in other areas, because it's heaps cheaper than ACT. And you tell people the ACT stim's $300.
Which is a cheap stim test, actually.
And then, but then you tell them the UCCR, I think it's like $50 or something like that. It's really cheap. So it's much happier.
Yeah, and as long as everybody understands the limitations of that test, like you're not diagnosing Cushing's on that, if it comes back positive, you're still going to need to do more tests, so you've spent more money in the long run, but it's a really nice rule out.
Yeah.
Why is first morning important for that test?
Can't remember.
More concentrated.
Oh, I think
the ratio. So.
I think you call it cortisol secretion is diurnal, but I can't remember, and it's more overnight. But I can't remember why you would want to. You could, like, you're trying to rule out Cushing, so yeah, I'm not sure.
I mean, it's a kind of reliable time to get a wee sample with a dog.
Yeah, true.
I'm going to forget to ask if I don't ask you now, but you said that Labrador. Did you say there's an association with laryngeal paralysis in that case example?
No association, but if I saw a dog with laryngeal paralysis that was panting, I thought the cause of panting might be Cushing's, I'd be worried about panting causing swelling, which would exacerbate the laryngeal paralysis.
Right. Okay.
Yeah. So that's just the sort of the thing that makes me go, okay, we're looking into this and we're going to treat it quite aggressively because we want to reduce the panting.
Hannah, can I ask about the ACTH stems? I know in general practice, we tend to do them every so often on animals that we're treating. Do you think that that's really necessary then, or should we be just looking at these clinical signs the owners report? Is that more appropriate? Because I know recently I've had a dog that's outside the values, still quite high. The dogs that are so to deal with anyway.
Yeah.
Should we be, is it necessary to be doing this every 3-6 months, checking this dog, or do we just say, well, look, she's managing well, leave her be?
Yeah. And I think that's the philosophical question of the day, because you'll get people who are really, no, it's fine. And I think it warrants bringing up, particularly because we do have a lot of people working in general practice and trying to make these decisions. There's no right answer here. You'll get people who are strongly opinionated on both sides of the fence and who say absolutely must be managed tightly to control the numbers. And you'll get people who say it absolutely should only be managed to control the clinical signs. And then you get people like me who really judge it on what were the complications that this dog was suffering from, how much were they impacting this dog's quality of life, and how much is my treatment resolving that complication. So if I've got hypertension, I'm not going to sit around waiting for the trilostane to kick in to resolve the hypertension, because it's not going to work. Or if I've got like PTE or it's had a stroke or something like that, I'm not going to rely on my Cushing's treatment to resolve that. I'm just going to control for clinical signs and treat the complications separately. But if I've got panting in a Labrador with laryngeal paralysis who's deteriorating rapidly in a respiratory sense, I'm going to treat them really tightly. And if I'm treating them aggressively to just get rid of clinical signs abruptly, I'm doing a stim test just to make sure it's not going too low.
Yeah.
That's in my mind, that's the only indication for ACTH stim monitoring, is to make sure you've not pushed it too hard.
But that could happen at any time, right? So you do need periodic monitoring to make sure you're not getting close to overdose.
If you see
goes more frequently at the beginning of treatment.
It does happen more frequently because we get the adrenal necrosis usually in the first few months of treatment. So I always do one stim test, always across the board, just to see what impact the dose that I started on had. But what we know about the duration of effective trilostane is that it lasts for between 8 hours and like 28 hours in different dogs. So in some dogs, we're always doing our stim test between 2 and 4 hours after dosing, so at the nadir, right? So we're trying to catch the cortisol at the lowest point of the day. It might escape and be high, like off the scale high, for 18 hours of the rest of the day, or 16 hours of the rest of the day. Or it might be going down to a nadir and staying low the entire time. So in your patient who's got LAPA, and you've done a stim test and you've seen that it's like numbers are great, but it's still panting its head off overnight, I'm going to modify my management and be a little bit more conservative on my dose in the morning and double it at night, like do a twice daily dosing in that patient. So I would very much not just ask clients about what the clinical signs are, what the complications they're suffering from are, but the timing of that suffering relative to dosing, and work out what's going to work best for this patient. But if you've got a dog on twice a day trilostane, what it's doing in them after one dose is, like, you don't want to be super, super tightly controlled because their 24-hour cortisol level would be so much lower in those twice daily dogs. Does that make sense?
Yeah.
I don't think the number tells us enough information. It's a very clinical disease with the complications. The impact that the complications have on different patients very different. So there's no right or wrong. But very much listening to the owners and saying, what are you concerned about? Are you noticing frequent urination through the night? Are they still really thirsty through the night? And in that dog, I'm probably going to put them on an evening dose as well to try and even out their cortisol level through the day.
But isn't the recommendation now to do it twice, tyrosine, like in terms of, and this may be just bookish knowledge I have, that it's like 1 mg twice a day?
Yeah, so the recommendations from the consensus statement in 2013 were either 1 mg twice a day or 2 SID.
Now, is there when would you worry that something's not quite right? Because I recently, a colleague, like just this week, and I said we should do some research this weekend because this particular dog, it's like a Bichon, so like 5 kilos or something.
Yeah.
Currently is on, I don't know the absolute details and the numbers, but currently is on 8 mgs of trilocin twice a day. When I heard that, I fell off the chair and I was like, oh, we need to, like, something's not right. We need to
8 mgs per
investigate
kg?
why. Yes.
And it's a what? What breed?
Bichon. So that's like, we need to look at why this dog is not controlled.
Is it pituitary dependent or is it?
I don't really know the details, but that prompted in my head to look into, is there a maximum dose? Like, I've never heard anybody talk about this. And if you're reaching that high levels, then how do you even start investigating why is this dog not responding? Or what is happening? But there are no neurological signs. So, because one of the thoughts I had is it a macroadenoma? But then the dog's not according to the owner, the dog is completely fine. She did say the dog is drinking more. So then I said to my colleague that maybe you ask the owner to actually quantify instead of just saying drinking more. And then we told her how to quantify, and the amount she's come back is nowhere near 90 mils per kilo, sorry. So obviously not PD, but the owner's perception is drinking more, but that's not really, it's not actually drinking more, because if, like, I'm again thinking, if you're really talking about polydipsia, you have to have more than 90 mils per kilogram per day.
Yeah.
But the dog's on 8 mgs per kg, and that's a really high dose. And I'm like, I don't think
it is, but my own beagle was in the original trilostane registration trial when I was in high school, and Jodie Braddock was running it. I used to take my beagle into the uni and get Jodie Braddock to do stim test on it, and it was on 18 milligrams per kilo.
Wow. So you can't, so there's no upper limit per se.
No.
Okay.
No.
Wow.
You just keep going until the clinical signs are resolved. So that's where I'd sort of say, okay, what are we missing here?
Yeah.
Is it maybe this dog's just got a really short duration of action of trilostane, and we're getting escape through the rest of the day, and that's why we're still seeing these clinical signs. And maybe the total day's thirst doesn't exceed 90 mils, but in the evening he's doing 140. So I would just really knuckle down on the timing there. I wouldn't be too worried about what the dose is. You've worked your way up there. She's not low, and that's what you're trying to avoid by using low dose. So I would really knuckle down on timing on that one. And it might be is it on BID already?
BID already, yeah.
Yeah, okay. It just might be a really high dose dog, or there might be something else causing its PUPD.
Yeah.
Let's talk about quickly, because we're nearly done. When would we use? Okay, what's the merit of ultrasound in dogs that were suspicious of Cushing?
Ruling in/out an adrenal.
Good.
So if you don't see an adrenal mass, you can be suspicious that it's more likely pituitary dependent. As you said before, sizes are really debatable. So both being big or upper end of normal doesn't rule in Cushing's, but if you see one really big one or one massive pole or a mass, and then the other one's really little, you can be concerned about adrenal dependent.
Good. And I think that's the really important point, is that the other adrenal needs to be atrophied to diagnose adrenal dependent Cushing's. Every now and again we get dogs with pituitary dependent, which get nodular hyperplasia on both adrenals, and then one of them turns into a carcinoma and starts producing cortisol, so they get both pituitary dependent and adrenal dependent. That's tricky. But most of the time an ultrasound will differentiate for you pituitary dependent versus adrenal dependent, which means you then aren't so reliant on the low dose DEX. What pattern would we look for in a low dose DEX to tell us it's adrenal dependent as opposed to pituitary dependent?
Adrenal doesn't have this suppression at the 4 hour, and
Good.
Does have this suppression at the 4 hour.
Very good. Excellent.
I had no idea.
Yeah.
I'm like, I've done one low dose DEX so far in my career, and that's still a good 4 or 5 years ago. It was pretty early on.
Yeah. It just takes so long. Like, I think you've got to have dogs that aren't very stressy to be in the hospital for that period of time, without sort of causing a false positive. What's the split of how many are adrenal dependent and how many pituitary dependent?
85.
In Australia, it's about 90% or so pituitary. In America, they report 85%.
What's the split if we just look at large breed dogs?
They'd be more likely the large breed dogs, more the American finding, which is the 85%.
Yeah, so just looking at large breed dogs, 30% of them are adrenal dependent, 70 pituitary. So much more likely to be adrenal dependent in a large breed dog. Large breed dogs tend to be less stressy in hospital. That's a generalization. So if I didn't have access to ultrasound, I would potentially lean towards a low dose test rather than a stim test to help me differentiate.
And do you check if your owners are actually likely to manage it as an adrenal tumour or just use trilostane anyway before you're going to make that call?
I think a good reason to differentiate is because the adrenal dependent ones are harder to manage with trilostane. That often require higher doses, which somebody said when Pooja mentioned the dose that they were giving this dog, is it adrenal or pituitary? Yeah, and I think that warrants investigation because adrenal dependent tend to require higher doses, and you tend to be just so that you suppress the cortisol production and then the tumor gets bigger and you need a higher dose of trilostane to suppress the same amount of cortisol to end up with the same amount of cortisol. So they're harder to manage. I'm more on top of like rechecks in those dogs, but that's really the only reason, unless they're likely to go to surgery, in which case absolutely good reason to differentiate.
Is the other benefit of ultrasound that at this point in time there could be other things that cause hypercoagulability or gallbladder mucocele or stones or things like that, so you got to kind of have a look at it.
Yeah, absolutely, for sure. And there's, I mean, these are old dogs, there's comorbidities, there's reasons why you wouldn't go down the track of looking into, you know, if you find a big liver tumor as the cause of the ALP elevation and the adrenals are big, you're probably not going to do your stim test at that time. You're going to deal with the liver tumor first. Just looking for comorbidities which might make it harder for you to make your diagnosis. 1 minute left. Last requests.
If an owner's like cost constraint, I mean, it's probably irrelevant because they probably won't treat or test anyways, but if they're looking into it and you do an ACTH stim test, say, and it's positive, do you need to do an ultrasound before starting diagnosis, or how much do you need, like what, do you have to have more than one test to start treatment? I think someone else kind of touched on this before.
You don't have to, absolutely not. But I guess if they're really subtly affected and you're sort of thinking, are they Cushingoid or aren't they Cushingoid? And you do your stim test and it says they are Cushingoid, and you say, okay, well, let's start treatment. In my mind, that patient didn't need treatment yet.
Okay.
So, you know, you've got your cost-constrained client and you tried to save the money by avoiding the ultrasound, but you've cost them $600 per 6 months in trilostane, when that dog in 6 months might need treatment, but right now it doesn't.
Yeah.
So I would sort of say that if it's subtle, then no, but if it's like poster child, this is Cushing's, just do a stim test and get on the treatment.
Yeah, cool.
Yeah, so if they're really severely affected, for sure.
And if you see the changes on ultrasound, but you haven't done a stim or anything, can you treat based on that? Or you'd recommend doing those tests as well?
Ooh, circumstantial. So
Like
if it has a concurrent disease, like in a diabetic, if I had a diabetic dog and I saw adrenomagaly and liver changes, I'm not going to start it on Cushing's therapy because I expect adrenomagaly and liver changes in a diabetic dog. So whereas a dog, yeah,
Anna, you can say Katie's on surgery and you're like, they're not as particular as
no, they're not. Yes. So I would just do it based on circumstances.
Okay, great. Thank you.
All right, I'm wrapping up.
Thank you.
Thank you so much. That's awesome.
No worries. I hope everybody learned something about Cushing's, even though everybody knows everything about Cushing's already.
I definitely didn't.
Good. It's the stats I find exciting. Okay, we'll see you in a fortnight. I can't remember what we're talking about, but it's probably going to be really interesting.
It will be.
Yeah.
It is.
Thank you.
No worries. Bye.
Thanks, Anna.
See you, everyone. Have a good day.